Good afternoon, everyone. Not sure if the mics, mics are on. Good afternoon, everyone. It's still good morning for me. I literally just arrived about an hour and a half ago. It's great to be in India again. This is my favorite country to visit, and it's been a pleasure visiting this over the years for a number of times a year. So Uni asked me to give an update on hypoglycemia in type 2 diabetes. Whether it's an increasing problem or not. Before I start, I'm just going to ask a poll question. How many people think it's hypoglycemia is decreasing now that we have better drugs? How many think it's increasing? How many think it's still stable? So more for increasing. Sulfonylureas are a significant problem for hypoglycemia. How many people think that? All right, so let's see if we can do some myth busters there. These are my disclosures. So I'm just going to go through, over the next few minutes, prevalence and rates of hypoglycemia globally, trends for hypoglycemia published in the last few years, trends in outcomes following hypoglycemia, very little data on cost of hypoglycemia, and then summarize and see why there are so many differences in certain conclusions that we come to. In terms of the prevalence and rates, this is one of the largest studies in hypoglycemia in type 1 and type 2 diabetes on insulin. This was 25,000 patients globally from 24 countries. And the interesting thing about this was it was a retrospective study when the patients were included, but then a prospective diary-based study, because there's a lot of issues with the recall. People forget when they've had a hypoglycemia, so the best way to do studies is by doing them a diary. What this shows is overall, over a four-week prospective period, and we then converted them to annualized rates, is overall we get overall rates for type 2 diabetes is about 20 per person per year. This is any hypoglycemia. When we go to nocturnal hypoglycemia, it's about 5 or 6. And we see that Southeast Asia is represented here, on the last bar here. So 20 seems quite a lot. And we had difficulty getting this published because people thought there is no way it's this high. And the reason we didn't have any other data was because most of these countries don't have data. India at that time did not have any rates for hypoglycemia. When we look at severe hypoglycemia rates, for some reason, Southeast Asians seem to get more severe. This is 3.4 severe episodes per person per year compared to the global average. And we've been doing some work in the UK looking at South Asians and whites. We think there is a difference in the way South Asians perceive hypoglycemia, and there may be that there is an increase in rates in South Asians. And the reason is most of the diabetes studies in terms of identifying people who have hypoglycemia have been done in white European populations. So all the CLAMP studies have been done in whites, not in South Asians. What's the consequence? What do people do as a consequence of hypoglycemia globally? So this is patients requiring extra visits. And again, if you see Southeast Asia, this is type 2 here. They seem to access clinics a lot more. And this is, again, Southeast Asia requiring telephone call or contact with medical personnel. So the behavior following hypoglycemia seems to be different in different countries, with Southeast Asians going for more contact with healthcare professionals. Because we had difficulty convincing people, we did a systematic review of looking at all the studies, real-world studies, of hypoglycemia rates in people with type 2 diabetes. And what we found here was overall the conclusion of the HAS study, which I've just shown you, the incidence is comparable to real-world studies. So basically, we seem to get more hypoglycemia in the real-world setting than what we see in a trial setting. And the reason is, in a trial setting, many participants would be excluded. For example, hypoglycemic agent trials, if they've had hypoglycemia, especially severe hypoglycemia in the last 12 months, they would be excluded from the trial. These patients are also better informed, etc., while this was a real-world study of all comers. This is a systematic review of observational studies, 46 studies, over 500,000 people looking at mild to moderate and severe hypoglycemia. If we just concentrate on severe, proportion of patients getting hypoglycemia, 21% on insulin. If we look at sulfonylurea, 5%. But the interesting thing is, even non-sulfonylurea, there are 5% of people experiencing some form of mild, moderate, or severe hypoglycemia. The problem with this study, again, was that most people do not say which sulfonylureas. They just lump all the sulfonylureas together, and we know there are differences between sulfonylureas. This is looking at the rates of hypoglycemia, and again, let's go for just the severe. Rates of hypoglycemia, insulin, 1 per person per year, which is about right, what you see. But when we go to sulfonylureas, diabetes, severe hypoglycemia, and is not a huge problem. This is looking at any hypoglycemia, 0.01 per person per year in a real-world setting. So this is the latest study that we've conducted. This is prospective diary for 1 year. So all these people did a diary and sent it to us on a monthly basis, just over 300 participants. And this is annualized rates, incidence per person per year. None in metformin, sulfonylurea, 0.12. And this is looking at a blood glucose of less than 3, what we would classify as a severe hypoglycemia. You hardly see severe hypoglycemia. Insulin, 1 per year, exactly like we found in the systematic review, and incretin-based therapies, again, low. So overall, with sulfonylureas, you get low rates of hypoglycemia. Carolina, you all know about, and Carolina, the headline news was that there was no difference in cardiovascular outcomes, but there was a 77% reduced rates of hypoglycemia favoring linagliptin compared to glimepiride. Glimepiride does have higher rates than glycoside, but when we drilled it down further, so this is looking at severe hypoglycemia, this is hospitalization for hypoglycemia. Numbers needed to treat 270 over 1 year with linagliptin compared to glimepiride to get one benefit. Numbers needed to treat 600 for 1 year to avoid 1 hospitalization. They're not huge rates. Now, trends in terms of hypoglycemia rates, these are some large database studies. This is looking at Canada. We see overall there is a decrease in Canadian rates over time, especially since 2009. So some countries are showing reduced trends, and mainly this was driven by increase in DPP-4 inhibitor prescription that happened at that time. There's also seasonal variations, which I found very interesting. This is a very recent study looking at variations by month, and there is a peak between April and June. This is data from Canada. I couldn't find any other studies anywhere else that look at seasonal variations. But again, I can't explain what the reason is for these seasonal variations, but there's certainly an increase, in about 5% increase during those months compared to other months. This is data from UK, very, very large database. This is looking at trends in HbA1c over time. We had a pay for performance that came here. You see HbA1c reductions here, proportion of patients getting HbA1c below 7%. Sorry, this is the mean HbA1c. Sorry, I'm not sure what's happening. This is the mean HbA1c. No, we're not going to see this here on here. Mean HbA1c in the dark line, solid line. In people on the left-hand side, young people with type 2 diabetes, less than 64. On the right-hand side, more than 65. Overall, there is improvements in HbA1c, but the improvements were driven because of pay for performance. Pay for performance said, get your HbA1c below 7.5% and you get most of the pay. So we've become stagnant at around 7.5% because they're not paying for anything below that. In terms of prescribing trends, we've seen increase in prescriptions of metformin, of DPP-4 inhibitors, and recently in SGLT2 inhibitors, both for young and for the old. But if we look at hypoglycemia rates, there is an increase. This is incidence on the left side per 1,000 person per year, increase in the young people with diabetes. However, in the older populations, we've seen a decline over the last few years. So we're not treating the elderly as aggressive, but we seem to be treating the young aggressively, and this coincides with this increase in hypoglycemia rates. This is Francesco Zaccardi, one of my researchers. We looked at data for the whole of England. We're very fortunate we get really good data in the UK. This is the whole of England, every admission for hypoglycemia in the English hospitals, looking at trends from 2005 to 2014. At the bottom here, these are people who are young, most likely type 1, and here type 2. What we see is a couple of things. There is an exponential increase in hypoglycemia admission in the elderly starting at around 60 years of age. However, despite having good quality drugs, we don't seem to have had any change in admission rates. So we're either not using the new therapies appropriately, or we're treating the elderly patients more aggressively. And there is data to show that as well. This is looking at US data set, again, a very, very large data set. And these are events per thousand again here. These are short-acting insulins at the bottom. This is long-acting insulins here. This is looking at insulin secretagogues and other drugs. And what we see is there is no change over the years. Despite good quality therapies, we still have much high rates these are very, very severe hypoglycemia rates. The other issue is having comorbidities. That's an important issue. If you have comorbidities, you're more likely to get more hypoglycemia. This is from the same study looking at the trends in hypoglycemia rates over the years, adjusted rates from 2005 to 2011. But what the interesting thing is that the rates in the elderly in this study as well are still high, just like what I showed you from the UK. But if you have comorbidities, so for example, CKD, your rates are much, much higher. You have heart failure, your rates are much, much higher. If you have previous cardiovascular disease, your rates are much higher. And surprisingly, if you have depression, your rates are much, much higher as well. This is another large study by Lipska from the US showing that overall, they've seen reduced trends for admissions for hyperglycemia here. But in terms of hypoglycemia, there doesn't seem to be any decrease. Overall, pretty flat curve there. This is the same study, again, showing that the rates seem to be twofold higher in the elderly. Why are we treating these elderly patients so aggressively? We've got patients in the US, in the UK, I don't know about India, who have an HbA1c below 7%, they're age 75, they're on insulin, they're on sulfonylureas. This is where we need to be stopping therapies, not escalating therapies. This is the latest study, really nice study from the US, looking at ethnic differences. And again, in the US, that they're seeing there are ethnic differences. These are the trends, these are black populations, these are Hispanics, and then these are the whites. There has been a decline overall, but in certain ethnicities, but overall flat rate in terms of serious hypoglycemia. These are emergency department visits. And again, what we see is a number of comorbidities. If you're a multimorbid condition, diabetes is a multimorbid condition. If you have diabetes, only 17% will have diabetes and no other condition. If you are aged less than 65, you have diabetes and 2 other conditions. If you're aged more than 65, you have diabetes and 5.5 other conditions. So people with diabetes have multimorbidity. So the more conditions you have, the higher the risk of hypoglycemia is. So this is severe hypoglycemia. This is 3 to 4 conditions, 2 conditions, and this at the bottom is not having any conditions. And also, which conditions matters as well. So this is looking at the bottom here, cardiovascular conditions. This is having advanced diabetes complications, and if you've got both advanced complications and a cardiovascular disease, then your rates are even worse. So what about trends in outcomes following hypoglycemia? There's not many studies in terms of trends in outcomes. There are some data. This is, again, our group looked at this. So we looked at the global burden of hypoglycemia-related mortality from 109 countries. WHO hold data for each country. So we managed to get data for each country in terms of the rates for hypoglycemia deaths, diabetes rates, and overall deaths, and adjusted by year and adjusted by age as well. So this is what we call a Choroplethmap. At the top, this is age standardized proportion per 1,000 of diabetes deaths. And as you can see, the rates seem to be higher in here, South America. This is age standard rates for the whole population per million related to hypoglycemia. Again, it seems to be much higher in South America. And this is looking at trends in proportion of hypoglycemia-related deaths in the 30 countries that we had the trend data, and looking at year 2000 as a comparator. So what we see here is in terms of total diabetes, or hypoglycemia death rates compared to diabetes death rates. And we see that there was an increase and then there's a leveling off since 2009. This is looking at trends in incidence rate ratios for hypoglycemia-related deaths compared to any death rates. And again, we see overall there was an increase, but now there's stabilization in death rates compared to the whole population death rates. This is data from US, and again, we see overall that these does seem to be reductions in 30-day mortality by 13% from 1999 to 2009. One-year mortality, there's about an 18% reduction. 30-day readmissions, about a 7% significant reduction. So some countries are showing that there are changes, some countries that they're showing that there is leveling off. What about looking at randomized controlled trials and the real-world setting? This is randomized controlled trial. You know this data. Sofia Zungas from the Addition study showed that if you have a hypoglycemia, you have a threefold increase rate of major microvascular outcomes, a twofold increase of microvascular outcomes, and a threefold increase in risk of all-cause mortality. Well, we replicated this data in a real-world setting, looking at both type 1 and type 2 on the right-hand side. We replicate exactly the same sort of rates that Sofia Zungas found in a trial setting in advance, but we advanced the findings from there a little bit further. First of all, advance was only in people with type 2. We looked at type 1 and type 2 in this large database. So the rates were similar, but what we found was that you can superimpose type 1 and type 2. Okay, so the first time you can see in terms of the event rates, incidence rates are similar for type 1 and type 2. But if you go for cardiovascular events following hypoglycemia or all-cause mortality, the rates are similar. But if you have cardiovascular disease and no cardiovascular disease, then your rates are 2 to 4-fold higher. See, showing that if you have established cardiovascular disease and you have a hypoglycemic episode, your event rates for a subsequent cardiovascular event or mortality will be 2 to 3-fold higher. So if we do anything, we need to avoid hypoglycemia in people with established cardiovascular disease. And again, Sophia showed that once you have the event, most of the cardiovascular events or mortality occur within the first 24 months. Okay? Majority of events seem to be in the first 24 months. We replicated this in a real-world setting, showing that both with type 1 and type 2 diabetes, time from first hypoglycemia episode to cardiovascular event was about 1.5 years. Time from first hypoglycemia episode to death was about 9 months to a year. So again, showing if someone has a hypoglycemic episode, you've got a window of about 9 months that you need to do something about that patient to reduce their risk of additional events. In terms of cost of hypoglycemia, there is very little data out there, good quality data. This is from US in terms of the trends for hospitalization, discharges for hypoglycemia by age group. So this is at the top, 85 years and more, 60 to 84, 45 to 64, and 18 to 44. And what we see is overall the trends have increased, which I've shown you in some countries. In this case, from this database study, there is a trend in increase, and the increase seems to be more in the younger group than the older group. The cost of managing hypoglycemia at the bottom over the years has remained the same, about $10,000 in the US per person. Sorry, 10,000 per year. But if you look at the total cost has increased because the burden has increased. The number of people being admitted has increased. So now we're looking at a $1.6 billion cost in the US for managing hypoglycemia, although the total average cost per patient has remained the same. So see, there are differences in different rates, different regions. What are the main findings from looking at the evidence base? First of all, hypoglycemia event rates are frequent in real-world setting compared to randomized control trial setting. We see overall that there is either no change, but in some countries, some decline in hypoglycemia, and I'm talking mainly of severe hypoglycemia or admission hypoglycemia. But there are large variations. So if we look at the whole population of hypoglycemia, we have non-severe hypoglycemia, then severe hypoglycemia. Severe hypoglycemia, you'll get a severe hypoglycemia and it'll be treated at home by the family. Otherwise, there will be a call out from ambulance. When the ambulance comes out, ambulance will treat the hypoglycemia. They may not be converted to the emergency department. And about, looking at global data, 1/3 will be taken to the hospital. Once they're in hospital, many will be discharged after management in the emergency department, and about 50% will be admitted. So when we look at the rates, we need to be careful. What is the definition of hypoglycemia? Whether it's hospital admission, whether it's ED visit, whether it's an ambulance caller, or non-severe. And that's why we see there are different rates. And so the exact reasons for these rates can be explained by differences in design of the studies. So it could be electronic health records, registries, or cohorts, type of diabetes, the exclusion and inclusion criteria of the patient population. Have they included everyone or people with multimorbidity, by age, by frailty? There's also differences in treatments globally as well. The definitions of hypoglycemia are different as well in terms of, as I've just mentioned, is it ER visit, is it admission, or is it severity? There are differences in the denominators used. There's different methods of recording for hypoglycemia, and I personally believe there are differences by ethnicity as well. Whatever the difference, the ultimate aim really is to reduce the rates of hypoglycemia through education and the appropriate pharmacological interventions with this rising rates of multimorbidity and the aging population. Thank you very much for listening.